tuning in to the World XP podcast. If you're enjoying the content, please remember to drop a sub, drop a like, and leave your thoughts down below in the comments. With that, we will see you guys in the podcast. Welcome, Dr. Nirschl, to the World XP podcast. For those that don't know, this is my granddad, so I've known him for my whole life, pretty much. This is going to be the beginning of a podcast series on sports medicine. For those listening that don't know, Dr. Nirschl is an orthopedic surgeon. He is the founder of the Nirschl Orthopaedic Center for Sports Medicine and Joint Reconstruction, as well as the founder of the Virginia Sports Medicine Institute. He won the Mayo Clinic Distinguished Alumni Award in 2017. He won Alumni of the Year for the Medical College of Wisconsin, has done over 400 medical presentations in the U.S. and 9 other countries. He's written 94 book chapters, 163 published medical articles, 10 video programs on orthopedic surgery techniques, and a multitude of others that I will put in the description at the end for you guys to read. But welcome, Dr. Nirschl / Granddad. Appreciate your time.
Well, it's awfully good to be with you, Eric. It's always good to have somebody who's knowledgeable and who is talented to be able to do podcasts. So this will be a series of sports medicine topics, and it actually could go on for quite a while. There might be at least 25 different topics that we could go over, and we could go from common problems, conditioning in sports, to all the way to injury prevention, and also to treatment, including non-surgical and surgical treatments. And we could start out today, I think, with what is tendonitis, and is it an obsolete term? And the facts of the matter are that tendonitis term has been used for 100 years and is totally obsolete. And the work that we did here in Virginia identified that there are no inflammatory cells in damaged tendons, and therefore the term itis came from, of course, the Greek, which means inflammation. But since there are no inflammatory cells in the tissue, therefore the term itis is inappropriate, and we discovered that on our investigations and research on tennis elbow.
So how did you get around to like even working on this, or figuring out that, right, you see tennis elbow and you're like, well, there's no inflammatory tissue in the tendon? Is like, how did that come about? This even sort of cross your mind that tendonitis might not be the right term for it?
Well, to start with, I was a high school athlete. I actually had 3 letters in sports: football, basketball, and tennis. And and I was always interested in sports. And after I got to Virginia from the Mayo Clinic, I went back to tennis and got tennis elbow. And I am an inquisitive type of person, and so I started to read the orthopedic literature. This was in the late 1960s, and the first 2 articles that I wrote or I read in the orthopedic literature started out by saying tennis elbow is a terrible term because we've never seen a tennis player with tennis elbow. And
you were practicing already by this time?
Yes, I was.
You're good.
Yes, I was practicing at that time. So I actually, after I left the Mayo Clinic, I was a lieutenant commander in the Navy for several years as an orthopedic surgeon, and then I came to the Washington area, and then I was practicing, and then, as you said, I decided to get back into a little conditioning and took up tennis. And when I got to tennis elbow, as I said, I read the literature, and in the first 2 articles said that tennis elbow was a bad term because they didn't see any tennis players with the problem. Well, I knew that this was just totally incorrect, and that these authors really basically didn't understand it worth anything. So I started some research onto it, and the next thing that happened was that I filmed the United States Davis Cup team, including Stan Smith and Arthur Ashe, amongst others, and started to analyze stroke mechanics of quality world-class players versus non-world-class players or inexperienced tennis players. And we started to develop then the concepts of mechanics of good technique versus bad technique in terms of injury production or injury prevention. And once I got into that, then all of a sudden I started to see a wide variety of tennis players and who had tennis elbow, and then it came to the point where sometimes non-surgical treatment didn't work, so we moved on to surgery. And then when we analyzed the tissue with the pathologists and they looked at the tissue, they said, gee, there's no inflammatory cells in this tissue, and therefore we redivide the concept to what we noted. We called it angiofibroblastic tendinosis, which was there are a lot of blood vessel cells.
So before you go into more sciencey terms that people listening are probably their heads are almost spinning at this point, what is tennis? What is, for the layman, what is tennis elbow? What is that injury?
Well, tennis elbow is one of the tendinitis / tendinosis problems, and when a tendon fails, it fails by degeneration, not by inflammation, and so the issue then is when the pathology terms were changed, and this, of course, is for medical doctors to understand, and not for the lay folks per se. But it's important because the treatment up to that point, now this is the early 1970s, the treatment up to that point was anti-inflammatory treatment rather than trying to restore the health of the tendon itself. And so that it totally changed the concept of what to do with tendon failure. So
it's basically just a degeneration of the tendons that are in the elbow.
It's degeneration of the tendons in the elbow, but the tendon overuse problem in sport, and for that matter, just in occupational activities, goes from the shoulder to the elbow to the wrist, and also to the hip, to the knee, to the shins, and to the Achilles tendon, and to the plantar fascia, and the pathology or the failure of the tendon is always the same when you look at it with the microscope, when the pathologist looks at it with the microscope. So all of these maladies are similar, and they all come from generally overuse, but there's another important factor, and the other important factor is that people are born with a durability problem in tendons. So there are some people, in way of metaphor, some people, let's say for tires, some people are born with 10,000-mile tires, and some people are born with 60,000-mile tires, or some people are born with 10,000-mile tendons versus 60,000-mile tendons. And so it depends on what you're born with, and then it also depends on how you use it. So that if you have a 10,000-mile tire and put it on an Indianapolis 500 race car, it'll last about a quarter of a block. If you put it on a car, on an elderly person who goes to church once a year, it might last a lifetime. Yeah. So even a 60,000-mile tire on an Indianapolis 500 race car only lasts maybe 75 miles. So it depends on what you're born with, and it also depends on how you use your tendons. So when you get into sports, of course, then you're more active, and then it's sport specific. So for instance, in the racket and throwing sports, the upper extremity tendons get into trouble more often. In the running sports, the lower extremity tendons get into trouble more often.
Sure, and all of these thoughts and this research that you've done, this all stemmed from your own experience with tennis elbow back in back in the 60s.
Yes, it all started. All
So-
started with that.
So you start to figure out that maybe tennis elbow is not the right term. You figure out it's degeneration rather than inflammation, and this leads you to looking at the other tendons that are in the body that are being used by athletes, not just tennis players as well. Is that accurate?
That's correct. Yes. So that in the racket and throwing sports, of course, the shoulder is a major player, as well as the elbow. But there are many people who, as we said, have a durability problem, and I wrote an article actually in the late 1960s called the Mesenchymal Syndrome. Mesenchyme, everybody's kind of aware of it now with stem cells and things like that, which is a popular topic. But the mesenchymal group includes then muscle and tendon, and it also includes then what is in a tendon, and what's in a tendon the ladies are very much aware of, collagen, which is in skin, and so of course the dermatologists are into collagen and making skin better and so forth, but there is an enormous amount of collagen in tendons, and one of the failures then of the tendon is that the collagen becomes disrupted, and in addition the blood vessels get squeezed out. So it is, to use my term, a metaphorical term, is a heart attack of tendon, if you will. And so the treatment then, of course, of tendon failure is to restore the vitality of the tendon by bringing new blood vessel supply, just like the cardiology doctors do with heart attack victims.
Sure.
So, for instance, in a heart attack victim, the heart muscle dies to some degree. That's what a heart attack is all about. And so in the old days, the cardiology doctors, God love them, basically gave terrible advice. They said, well, you had a heart attack, that's serious business. You better just sit in a chair and you better not stress yourself, otherwise you'll have another heart attack and you'll die. And that was terrible advice, because what happened was that the individual was petrified, sat in a chair, their cholesterol went up, their fat went up, and they were worse off, and they died and fell out of a chair anyway. So now the cardiology guys are more educated, and they say, you know, a heart attack is serious business, but you better get out of the chair and you better do cardiac rehab. So you better start doing rehabilitation to revascularize your heart muscle. So the same thing is true then of a tendon failure or a heart attack of tendon, and that is that rehabilitative exercise to encourage new blood vessels to help the damaged tendon and to heal it is the way to go. But you have to be controlled in your rehabilitative process so that there's specific rehabilitative exercises in which are appropriate to this.
So
Now,
how did you figure those out, right? So you've got tennis elbow, or for example, like my patellar tendon is not in, or used to be not in great shape, and I've done different exercises to sort of fix that. How did you go about figuring out like what different exercises don't put the strain on the tendon that, for example, like helps it to regenerate rather than degenerate more? Because there's all sorts of different exercises, right? Like there are some days that I wouldn't be able to do squats because my patellar was so like degenerated and it was so painful that it didn't help. But then if you do maybe like a pistol squat or something that's like later on the body, then it's like, okay, then that will help fix it. So how did you go about figuring out which exercises would be able to help, and was there sort of a pattern that you started to see develop for whether it's a knee or a shoulder or an elbow?
well, it's a great question, and pain is a helpful tool in that regard, so that anything that basically creates relatively intense pain is probably a no-no, so that we use that to start with, and then we gradually worked our way into the concepts of exercise from the points of view of the technique of the exercise, as well as the frequency and intensity of the exercise. So there are three components to the concept. Mm-hmm. And so in the early going, in the 1970s, this was trial and error to some degree. Now, there are also two kinds of rehabilitative exercise, and there are what are called eccentric exercise and concentric exercise, which is the idea of either shortening the muscle tendon unit or lengthening the muscle tendon unit.
Correct.
And so both are helpful in that regard. The other aspect of, we might digress for just a moment and also just discuss exercise in its own right. And in my scheme of things, there are three categories of exercise. Category one then is rehabilitative exercise, the goals of which are to take injured or deficient tissue and restore it to normal. Category two would be fitness exercise, the goal of which is to take relatively normal tissue and make it better normal. And the third category in my scheme of things is performance exercise, which includes sports performance. And the goal of performance exercise is not good health, which is actually a Nirschlism, which I coined actually in 1970. Because up to that point, people thought that, well, taking up a sport to get in shape, the facts of the matter are that sport very often causes injury.
That's for sure.
So you basically get in shape to take up a sport. You don't take up the sport to get in shape. So that's a Nirschlism from the 1970s. And we learned that on the basis of of when I filmed the United States Davis Cup team and then started to analyze inexperienced or non-world-class type tennis players and their stroke mechanics versus stroke mechanics of elite athletes, and found them to be totally different. And so good mechanics very often might be good for stroke production in tennis, but poor mechanics, you could still get the ball over the net, but also overloaded the tissues, so to speak. So that we started to analyze it, and then wrote a book on the basis of going good mechanics in tennis to start with versus bad mechanics. And then we started to develop other things as far as the treatment plans as well. So if you have pain, the problem is that you're not going to do much in the way of any kind of exercise. And so one of the important concepts of treatment to begin with is pain control. But that is not necessarily inflammation control. So pain control is very, very different than inflammation per se. But you need some form of pain control to help out so that you can do a good job on your rehabilitative program. The other aspect of treatment would be also, again, then to change the mechanics of what you're doing, so that looking at tennis players as an example, a punch backhand versus a smooth flowing backhand would be an example of bad mechanics versus good mechanics. And then you can do bracing, which we actually coined a new phrase called counterforce bracing, which had to do with the supporting the muscle tendon unit. And now you see a lot of tennis elbow straps as an example. But I was the first to actually introduce the term counterforce bracing in the early 1970s in reference to not only then the elbow, but the knee and the shins and the plantar fascia and so forth and so on. So all of those concepts are in play then. Number one then would be pain control. Number two would be rehabilitative exercise. Number three would be violence control or good mechanics. And number four would be some form of counterforce bracing. And if 1, 2, 3, and 4 don't work on occasion, the treatment would be surgical to take out the unhealthy, pain-producing damaged tendon. Now, there can also be a wide variety of volume in terms of tendon failure. It could be just a little bit of stress and a small amount of tendon failure, all the way to tendon rupture. And so there are categories then that we developed in terms of when we looked at it surgically of the variety from.
Before we go into the variety of tendon ruptures, tears, things of that nature, all of the things you mentioned, the 1, 2, 3, and 4 of pain management, mechanics, and the basically violence control, all of those things now, like for people that are in, like myself, is kind of, I wouldn't say second nature, but it's just there. Like people seem to know it. You being at the forefront of that back in the 70s, how, like, I don't want to say revolutionary because obviously it was, but how did you come up with these things? Because often you see an invention and you're like, well, obviously that makes sense, but to be the person that comes up with it, you have to like see something different than what everybody else is. So what are you seeing in these athletes in the 70s that you're like, okay, well, obviously pain management, this seems fairly, I say intuitive, but then the other ones in terms of, right, mechanics, a lot of times when people think of mechanics, you have mind-body connection, right? So which muscle is firing when you do a certain motion? Like with squats, you can be more quad heavy or more hamstring heavy, depending on how you do that. So how did you come up with all of these sorts of concepts, and then obviously the braces as well? That how to design them so they work properly in the way that's intended?
Well, actually,
you're good.
Actually, it might be surprising, but when I was at the Mayo Clinic, I had opportunity to participate in a polio clinic, and you'd say, well, how did polio have anything to do with sports injuries? And what I realized in the clinic that we had, there were 2,000 polio patients at the time. Now the audience nowadays has no idea about what polio was all about, but it was devastating, and it didn't necessarily kill you, but if you survived, you were left with major muscle deficiencies, and the muscle imbalances that I noticed in polio. All of a sudden, it dawned on me when we started to look at sports. And the imposed demands of sports on muscle imbalance. So my polio experience actually triggered me to thinking in terms of this. Now, for instance, sport, let's take a baseball throwing as an example. In baseball throwing, the front muscle groups in the shoulder strengthen, but the back muscle groups of the shoulder weaken. And so there's an imbalance then which is imposed by the demands of the sport. And that's what I mean by sport causes injury. And so from that point of view, then we recognize the muscle imbalance of the shoulder blade muscle groups in the shoulder weak, and the front pectoral muscle groups stronger. But my polio experience triggered me into understanding that this is a 360-degree issue, and so that in sport rehabilitation and actually in sport conditioning, you need to think about it in a 360 degrees. And so my polio experience actually is what actually triggered my thought process into the sport activity.
Very interesting. I don't think that's an answer most people would expect. But so you were before I asked you the other question, you were mentioning the different degrees of tears and ruptures in the tendons. So do you want to jump back into that?
Yes, in our surgical experience, and when we looked at these tendons in various body parts, whether it's the Achilles or the tennis elbow or the shoulder rotator cuff, the issue is that there are gradations of damage. So there could be a little bit of damage or a fair amount of damage, or it could go on to full rupture of the tendon. So if you're in a situation where there's a full rupture of the tendon, then that almost invariably comes to surgical intervention to actually reattach the tendon or to repair the tendon. In the smaller cases where there's just a little irritation of the tendon, the rehabilitation process works well. So we then devised a category of 1 to 4, where there's a little bit of tendon damage to up to 50% of tendon damage, to 75% of tendon damage, to 100% of tendon damage. Now, how can you figure that out clinically? Well, the MRI came along, and the MRI and sometimes ultrasound evaluation allowed us to actually analyze the tendons to some degree. But the MRI is probably the most effective of the diagnostic tools to determine that. But and we also use pain phases.
Just real quick, for people that don't know exactly what the MRI is, can you just go briefly and explain what that is and what it does?
Well, the MRI is a tool which, in essence, unlike X-ray, which uses X-ray beams, this uses sort of a beam which basically shakes up the tissue to some degree, and you get an image, and the image that you see, sort of like an X-ray image, but not by X-ray beam, actually identifies and the anatomy of the tissue, and so you can discern the normal tissue versus abnormal tissue, and then you can discern also the volume of the abnormality, if you will. We also use clinically we use pain phases as an example also. So I developed a series of pain phases 1 through 7, and 1 would be a little ache and pain which goes away by itself. 2 would be some aches and pains after a sports activity, but the ache and pain basically goes away with warm-up. 3, the ache and pain will go away, but it takes a couple of days. 4, the ache and pain doesn't go away with sports activity and warm-up, and 5, the pain is there even with just activities of simple activities of daily living, and 6, the pain basically is there at rest. Now, if you have pain at rest, in other words, it disturbs your sleep and so forth, that tells us almost automatically that this is more significant tendon damage than if you just only have an ache and pain which goes away. In other words, phases 1 and 2 versus phase 6. 6 or 7, which, as you said, pain at rest itself. Now, there could be pain at rest, for instance, let's say you have a hip pain, which is called a trochanteric bursitis, or tendon of the outer side of the hip. And if you roll over on it at night and it causes pain, or you have a rotator cuff problem and you roll over on it at night and it causes pain, that's different than if you're not putting pressure against the tendon. So that would be, you would have pain at rest when you're not putting any pressure against it, and that would be pain phase 7. So if you're in pain phase 6 or 7, that invariably means that there's substantial damage to the tendon. So that's a clinical clue. And in addition, then we would use the MRI as an anatomic, device to actually visualize the tendon itself.
Sure. So you've got, right, you talked about 6 and 7 and then the different grades. Obviously, people go through all of these different sorts of injuries. You'd hope that most people, you'd catch it at like grade 1, small damage, small tear, or pain phase 1 and 2. But obviously, we see sometimes it just ruptures and it goes straight to the full tear. What causes the different sorts of injuries? Obviously, we know overload, right? Like an overuse of the tendon can kind of end up, it's basically a slight degeneration, and can be fixed with physical therapy and a few months of basically staying off it, doing the right exercises to strengthen the areas. But what happens when there's not really pain and then it just goes?
Well, again, there are ways to basically injure yourself, and one way is by repetitive overload, and that would be the issue of tennis, for instance, the backhand in tennis. Repetitive overload over time would be a gradual attrition of the tendon. Otherwise, there could be single event overload, which is fairly common, for instance, in Achilles tendons, where all of a sudden there's a sudden burst and the Achilles tendon just ruptures. And so a single event trauma versus a repetitive overload trauma. Now, single event traumas often basically affect the ligaments. For instance, in basketball and football, ACL injury, ACL ligament tear in the knee is often a single event trauma. A fracture of your tibia. I'm mindful of way back when it's still played today. Joe Theismann basically fracturing his tibia. That's a single event, high intensity, trauma to the body. But most of the tendon problems have a tendency to be repetitive overload over time. But sometimes what will happen, there's a combination. There's some attritional gradual overload, and there's a gradual weakness, and then all of a sudden that weakness or vulnerability, then a sudden event, which doesn't have to be too big or too great, basically then ruptures an already vulnerable tendon, which is very often the case. So that there's combinations of what can occur.
Yeah. You mentioned Joe Theismann, and I actually had messaged a soccer doctor in England about this, but I had a question. It was last summer. There had been probably 3 or 4 really nasty, like dislocated ankle, leg break type injuries, and it seems to me the last like 3, 4, 5 years, at least the ones that are visible to a lot of people on the internet or whatever, it seems like there's been an increase in a lot of these like single trauma, but like these like nasty, really nasty, like dislocated ankle, compound leg fractures, ACL tears, etc. It seems like there's been an increase. Do you have any inkling or idea why that, or if that even is the case? It just seems like it is to me. Obviously, I've not looked into the actual numbers, but do you have any inkling as why that could be the case?
Well, yes, I think, first of all, the athletes in general are bigger, stronger, and faster. And that has to do with heredity, that has to do with nutrition, and that also has to do with conditioning, including strength training and so forth. So with more speed, more power, also means a higher intensity of collision, and that higher intensity of collision, I think, adds to the potential of single event injury. I think perhaps sometimes the sport is more aggressive as well. So sometimes that may be the case in addition. But I think the strength and speed of athletes today is much greater, and the potential for single event trauma is greater.
That makes sense. That's what I was thinking, but wanted to hear it from the professionals. There's number 3 one that you've got. It starts with an M, something syndrome.
Oh, the mesenchymal syndrome.
Yeah, let's go into that for a bit, because I think you mentioned that early on, and I wanted to get some more background before we went into the super sciencey stuff.
Yeah, so the mesenchymal syndrome, I realized also early that there were a significant group of patients who showed up with a variety of tendon problems. And that would include, at least in the upper extremity, patients would show up with a rotator cuff tendon problem in their shoulder, tennis elbow, both the lateral tennis elbow, which is the outside of the elbow, or medial tennis elbow, so called the golfer's elbow. And would also show up with carpal tunnel syndrome, or numbness and tingling in their fingers, and also would have what was called de Quervain syndrome, which is a tendon at the thumb side of the wrist, and they had this constellation of symptoms in all 3 or 4 areas, and that's when I came to, it dawned on me that there were people who were born with with durability problems in their tendons. And so I wrote this article actually in 1967, and that was news to a lot of people. As a matter of fact, there are a lot of doctors today who do not know this and do not understand it, and very often, the patients basically are very often not well treated because of a lack of understanding of it, and very often then another thing which is important, and that is that, for instance, in the elbow, it's not just an elbow problem, it's a whole extremity problem, including the shoulder blade and the upper back, as well as the elbow, so that in the conditioning or rehabilitation program for tennis elbow, for instance, you need to basically strengthen the upper back and the neck and the shoulder blade and the shoulder as well as the elbow. So the conditioning program is the whole thing. And as a matter of fact, for tennis players, very often, going back to stroke mechanics, very often inexperienced tennis players, one of my Nirschlisms is that experienced tennis players run a lot and use their arm less, whereas inexperienced tennis players run less and use their arm a lot. And so basically an inexperienced tennis player would stand there and say, well, the ball is coming, the ball is coming, the ball is coming. Oh, the ball is over the net. Maybe I ought to run. Whereas you notice world-class tennis players, they're on the move almost immediately, even before their opponent hits the ball. Mm-hmm. So even in tennis elbow, you need to strengthen the lower extremity so that they get to the ball in an appropriate position, so that for tennis elbow, then the rehabilitation program is not only the elbow, but it's the entire upper body as well as the lower body. So we realized that on the basis of analyzing the stroke mechanics of the world-class tennis players when we did all these motion pictures in those days and videos later on to realize good mechanics versus bad mechanics. And every sport has good mechanics and bad mechanics.
Yeah, that's for sure. Yeah, you see that with a lot of soccer players all the time, kicking techniques wrong, create imbalances and all these things, and then they have to go correct those imbalances. You mentioned the 360 approach to the entire body earlier, and as we've been chatting, just the amount of different, how everything is connected, it really makes you wonder how people function, at least athletically, because it seems like always there's something that can go wrong. If you had to give athletes advice on really making sure that their, we'll say tendons specifically, are in the best shape, or making sure that they're in the best shape to avoid injury, and we'll say discounting having good mechanics, because that's a gimme, but just what would you say to athletes, just to say, hey, you should do XYZ to make sure you're in the best position to avoid injury generally?
Well, now the tennis coaches are much better at it. I was one of the founding members of the United States Tennis Association Sports Science Committee in the late 1980s, and when we started that, we actually met with the and the United States Tennis Association arranged for the 20 best 16-year-old tennis players in the United States to meet, and we met actually in a small college in Northern California, and examined these 16-year-olds, 20 boys and 20 girls, and found that in the 16-year-olds, 75% of them had musculoskeletal deficiencies. In other words, they had weaknesses, flexibility deficiencies, strength deficiencies, posture deficiencies, and so forth. And so the concept then was, of course, is to seek out those deficiencies and then do sports rehabilitation to eliminate those deficiencies. And actually, with the 16-year-old kids, to begin with, we said, well, this will help to prevent injury. And with the 16-year-old kids, they didn't pay any attention to that at all.
Of course not. They're 16.
Yeah, and finally we changed our strategy and we said, this will help you to win. And then all of a sudden, a little bright light went on in their little minds, and they said, hey, well, maybe we ought to do this. But when we said this will prevent injury, it fell on deaf ears. So in any event, 16-year-olds, 75% had some deficiencies. So you can imagine what happens to 30-year-olds, and so that was a key thing that we discovered. Going back to the Mesenchymal Syndrome for a little while, then also, if you're born with those deficiencies to begin with, that on the basis of durability of tendons, then that adds another dimension to the problem. So those patients who have that, then they have to work doubly hard. So usually the mesenchymal group that I saw over the years was not the athletic group particularly, but could be another subset group, which is the occupational group. In other words, sitting at your computer all day long and wondering, why your back hurts, why your neck hurts, and why your shoulders hurt. And so that would be called workplace ergonomics, to change, what's the position of your chair, what's the lighting, what's the position of the monitor. So those would also be, for the workplace group, then that would also be, changing the technique of what you're doing in the workplace, in addition to, doing some exercise. So not only the sports issues, then it filtered down to the workplace issues as well.
Yeah, so you're getting patients coming in 70s and 80s, and you're figuring all these different things out and how they're interconnected, right? You mentioned the polio clinic earlier. How is it that you go about to sort of spreading this? Is it like, do a lot of the team doctors or the strength and conditioning coaches? Well, I guess maybe that probably wasn't a thing as much back then. But how do you go about spreading this knowledge? Is it more of you point to this athlete and say, look, we did this with him and now he's winning? Or is it just all of the above, giving presentations, writing papers and articles and just getting the word out there generally? Or did it take a while for this sort of new way of treating this to take hold?
Well, it took a while because not only did we have to educate patients, non-athletes and athletes, but we all had to educate doctors. I was interestingly enough, in 1974, I was the second doctor in the United States, and for all I know the world, to introduce actually fitness exercise machines in a physical therapy unit, and they were Nautilus machines at the time, and so the concept of having actual fitness tools like Nautilus and put that in a physical therapy unit and then start a sports medicine clinic at that time. I had doctors actually at our hospitals come up to me and say, sports medicine, what's that? Are you crazy? He said, that'll never do anything. I literally had doctors, and as a matter of fact, I had Nautilus machines in a hospital physical therapy unit here in Virginia, and the hospital administrator called me up about 6 months later and said, well, the doctors don't know what to do with these Nautilus machines, and it's taking up space. Would you mind taking the Nautilus machines out of our physical therapy unit? I kid you not. So this was in the early 1970s. So there was a lot of learning to go, not only with patients but with doctors. Now, from the runner's point of view, Dr. George Sheehan basically also started that in 1970. At the time that I was doing the tennis things, he was doing the running things, and he wrote a book called Running and Being. And then Jim Fix wrote a book a few years later called The Complete Book of Running. And so they were the first two books on running. And so at that point, if you saw somebody jogging in 1970 in the street, you'd think these people were crazy. And so I took a lot of grief in the 1970s and 1980s, trying to pave the way for all this stuff. And when I came up with the idea that tendonitis was not correct as well, I mean, I got all kinds of criticism from a lot of people.
Well, you must have seen the results right away, almost to say, like, to stick the course that strongly, because if most people getting that much grief would have been like, yeah, I don't know. But you obviously held firm, because we're here today still talking about it. And every physical therapy place I've ever been in is all sorts of exercise machines all over the place. So you must have been seeing results pretty significantly right away to be able to be like, nope, this is right, and this is what we should be doing because I'm seeing it in XYZ athletes. Is that a fair assessment?
Yes, absolutely. So I knew what I was doing was correct, and as we said, the rest of the world basically was on the wrong track, and actually I got into that along with our surgical technique, so that the Nirschl, for instance, tennis elbow operation is used worldwide, and I was the first basically to challenge what we were doing surgically in rotator cuff surgery as well, which was a standard of care at the time, which was really problematic to me as well. So I got a lot of grief, basically changing surgical techniques as well. So that brings up a whole another concept, which we can get into perhaps another time. But I had all kinds of issues, with challenging the old ways, if you will. But that's the way it is. And I knew what I was doing was right, and so I stuck to it. And now we know, 40, 50 years later, everybody does this stuff. But when I was doing it, I was one of the first in the world to do it. And as he said, got a lot of grief from it. But as time's gone on, everybody is now thinks, well, that's the way we always did it. Oh, yeah?
Everybody hates the new guy, don't they? We'll go with this last one real quick. Both 4 and 5 on your list both have a nerve pinch in them. So if you want to touch on nerve pinch, basically in the neck and the shoulder and like the upper back sort of area, you got rotator cuff, AC joint, things like that. How does that relate to the tendonitis / tendinosis stuff that we were talking about before?
Well, in the 40 and 50-year-olds, the Mesenchymal Syndrome group particularly, but also either other groups, very often will have a constellation of other issues besides. And a lot of doctors, I'm sorry to say, still don't recognize this. So all of a sudden you'll have a combination of some arthritis in the neck plus a nerve pinch problem, which comes down to the shoulder blade, and then will come down into the arm, which contributes to weakness and also contributes to pain. And then you can have that constellation of having a rotator cuff problem in the shoulder besides. And then, as you said, having the other mesenchymal syndrome group besides, very often confuses a lot of doctors, quite frankly. And over the years, I've so many patients who basically, were not well treated because the doctor, well-meaning, but didn't recognize the constellation of issues going on. So that, again, you have to think outside the box, and you have to be broader in your thought process. So I think in further discussions, what we ought to do is go down to then, specific, body parts. And so I think maybe the next discussion we might do rotator cuff tendon problems in the shoulder, and what we do with that, and maybe tennis elbow would be two that we could go into more detail as to exactly what we do, and maybe what the good surgical concepts are versus the surgical concepts which may have been old time concepts, but are really obsolete at this point, but are still done. and maybe try and educate the public a little bit and on the basis of those things. And then later on, maybe the topics of carpal tunnel in the wrist and de Quervain's syndrome, which is called the French washerwoman's disease, and then the problem with the soccer players where they get osteoitis pubis, in addition to adductor and abductor problems around the tendons of the hip.
I wonder who that could have been.
Otherwise, quadriceps issues, patellar tendon issues, anterior cruciate ligament injuries, knee meniscal problems, shin splints, and so forth. So we can go into all of those in more detail as time goes on.
Absolutely. You mentioned one more quick one. You mentioned the sort of the thinking outside the box, and you mentioned my injury with the adductor and the word that starts with an O that I've never been able to pronounce. I had talked with a fair few amount of physical therapists and other sort of people, and nobody seemed to really have a good handle on it. So it's interesting to me as I've gone through my own experiences, and I've heard other teammates have different injuries and be like, this place couldn't figure it out, that place couldn't figure it out. I guess it's just interesting to me that exists in the medical field, because everybody's body is different, and so different treatments might work for some people but not others. And then it lends me to say, oh, well, as an athlete, I have to know my body best first and foremost, and then kind of work with all of the medical people, whether it's the therapists or the surgeons or whoever. What are your sort of thoughts on that conundrum, I guess?
Well, I think first of all, you need to recognize that everybody is different, so different height, different weight, different flexibilities, different strengths and so forth, different mechanical angles. For instance, in the lower extremities, some people are born with knock knees, some people are born with bow legs, some people are born with flat feet, some people are born with high arch feet. So everybody's different. So you have to bring that into the equation, in addition to what sport they're doing, and then what the mechanics of the sport and so forth. So all of those come into play. And if you fail to do that as a patient or as an athlete versus as a doctor, you're not going to be as successful. So otherwise, if everybody is just the McDonald's of treatment, McDonald's works, but when you come to athletes and treatment and whatnot, you have to take the individual issue into account as well. But people go to McDonald's. Some people like the ham and egger, and some people like the McDouble or whatever, and so forth. So their stomach also tells them, what works and what doesn't work to some degree.
That's for sure. All right, Granddad, I really appreciate your time. This has been very educational, I'd say. Learned a lot of things, and obviously we'll get you back on, right, to talk about all the other things that you mentioned. We'll get into surgical techniques in different parts of the body in more detail later. But yeah, thanks. Any last nickels?
I think it's important to basically educate, because part of medicine is education, and if your doctor's not educating you and paying attention to you, then that's not really the best of medical care, if you will. So make sure that you're communicating with your doctor, and that your doctor basically listens to you. When I gave my talk, when I accepted my Alumni of the Year award from my medical school, my message to the doctors who were in the audience was, listen to your patients. You will learn a great deal. And nowadays the problem is sometimes our young doctors are very different in their own education and generation, from the point of view that they are now on the computer. And I would have patients come in and say, gee, the doctor never looked at me. All he did was basically punch on the computer, and he never really paid much attention to me. So it's important that there's actual communication and that the doctor actually listens to the patient. But it's also important for the patient to be accurate as to what their problem is. Sometimes patients come in and they'll wander around, so it's important for patients to write down exactly what their symptoms are and what have you. I'm reminded in that regard of a lady one time who came in, was in an auto accident, and basically she started out by saying she was going to the Safeway and she was going to buy some milk and this, that, and the other thing. And all I wanted to know was, where was the collision? So patients have to basically pay attention to, and to be accurate as to and precise as to what they need and what they want, so that there's a good communication between the two. But my message to doctors is get off the computer a little bit and look at the patient, and to pay attention to what the patient asks you and what the patient tells you.
Fair enough. Good message there to end this off. You can find the Nirschl Orthopaedic Center online. We'll put that link in the description as well as the Virginia Sports Medicine Institute. And with that, we will see you guys next time.